and welcome everyone for our Johns Hopkins Cochlear Center for Hearing and Public Health seminar series. My name is Jennifer Deal. I'm core faculty and associate director for academic training with the center, and it's my great pleasure to introduce our speaker today. I'm going to start with just a couple of announcements. So in terms of logistics, there'll be questions and answers after the presentation. If you are online, we ask that you please use the Q&A feature, and then we'll ask those questions for you on your behalf. Any questions that you put in that Q&A feature on Zoom will be sent to the panelists only, so not everyone will be able to see your question. Closed captioning is available and provided, and then we have a link provided here to access the transcript. Just to let everyone know, this seminar is being recorded. And if you do have any technical difficulties, please contact us at jhcochlearcenter@jhu.edu. So we want to make sure that everyone is aware of a really exciting event that we have coming up. It's our annual Cochlear Center Research Day. This will be held this year on Friday, April 19th. We start early in the morning with some really great presentations by some of our close collaborators. And then we run all the way through the end of the day through 3:30. We'll start in the morning, 9 a.m. We'll have breakfast available. And Dr. Lynn, who directs the Cochlear Center, will give a welcome and some updates. And then we really, starting at 10 o'clock, we'll have a series of talks that really focus around intervention for hearing healthcare by some of our great collaborators, and we'll get to hear more about the ACHIEVE randomized trial that we've been doing and different aspects of that study. At 12:20, we'll have our keynote address. This is concurrent with the epidemiology, the Department of Epidemiology current topic seminar, and we're really pleased to have Dr. Erasima Leroy with us for this time around, and she'll be speaking on hearing and vision rehabilitation and dementia, additional findings from the SenseCog program. Following that, we'll have lunch and a really amazing poster session by all of our trainees. And so we hope that you can plan to join us and attend as much as you can. It really is, I think, a great highlight of the year and one of the best days of the year. And so with that, I'm really pleased to introduce our speaker for today, Dr. Danielle Powell. Dr. Powell is an assistant professor in the Department of Hearing and Speech Sciences in the School of Behavioral and Social Sciences at the University of Maryland in College Park. She received her AUD from the University of North Carolina, Chapel Hill, and practiced in the greater Washington, D.C. area before she came to pursue her PhD in epidemiology here at the Johns Hopkins Bloomberg School of Public Health with a focus on the epidemiology of aging. Danielle then completed a postdoctoral fellowship in health services and outcomes research, working with Dr. Jennifer Wolfe in the Department of Health Policy and Management here at Johns Hopkins, where she was funded by the NIH as a health services and outcomes research T32 fellow. Dr. Powell's research is at the intersection of a lot of really important topics: hearing and hearing care, gerontology, epidemiology and public health, dementia, caregiving, health services and health systems level care, consumer-oriented health information technology, and implementation science. Her current work is funded through an Alzheimer's Association Research Fellowship grant to investigate innovative ways to support care partners of older adults with hearing loss and dementia, and we'll get to hear about that work today. And I was thinking about it this morning. I've been lucky enough to know Danielle for 7 years. And you won't see it from her CV, but there are some really important firsts. So Danielle is the first AUD to get her PhD in epidemiology here in our department. And she was also my first doctoral student. So please join me in welcoming Dr. Powell today. Thank you.
So nice to see basically almost all familiar faces and people I know out here. So this is a safe space to share kind of some of my work that I've done, either as Jennifer was describing during my postdoc and then more recently through my current funding. But essentially this work focuses around strategizing and trying to have a better understanding of how we can provide supports for hearing care outside of the audiology clinic for older adults. Focusing more on, again, as this describes, improving identification, diagnosis, and self-management for older adults. So as a brief outline, I'll go over a little bit of motivation of kind of why I'm interested in this type of work. A little bit of background for those that are less familiar on the role of care partners and hearing care delivery. Describe my current project and then some future directions on what I hope this project will inform. I don't think this is something that I necessarily need to tell this group, but over 73 million adults with hearing, we expect over 73 million adults with hearing loss by the year 2060. And a lot of my ideas for this work is kind of highlighted well within this graph on the joint prevalence and growth expected over the coming decades with our older population of both hearing loss and significant hearing loss that can affect overall daily health and function for older adults, but as well as that co-occurrence of dementia that we expect in future years. As many as 6 in 10 older adults with ADRD, standing for dementia here, Alzheimer's disease and related dementias, have a hearing loss. But what we don't know so far necessarily, or I should say there's a significant body of literature which does suggest that best practice hearing care facilitates social engagement, can decrease personal and family stressors and neuropsychiatric symptoms for older adults in general. And yet we know that hearing concerns are not regularly evaluated as best principles of kind of overall care and in particular dementia care as well. And therefore, that could ultimately leave gaps in how we think about and provide care for older adults, especially those with more complex care needs like that of dementia. This in turn, this underdiagnosis and underutilization of our current best recommendations for hearing care, there is some existing evidence that suggests can increase dementia-related symptomatology, caregiving stressors, and reduce communication ability for groups that the ability to communicate is already at a decreased level due to the effects of dementia. And there are a number of different recommendations as it relates to thinking about how we provide and support hearing care for older adults with dementia, including understanding how intervening on hearing loss in some way, whether that's hearing aids, the current gold standard for how we address hearing loss, or different communication strategies and rehabilitation works can help with some of the dementia-based symptoms as well as are, what am I saying, amenable to older adults with dementia, including some of potentially decreasing kind of the cognitive decline or risks, as we know from for certain individuals at risk for like the ACHIEVE study. But what we don't yet know, or I should say that what we have yet to determine really is how and when is best to intervene for hearing loss management to either potentially minimize dementia risk or the symptom presentation. The current recommendations that all of these things describe are ultimately the same as what we describe for older adults in general or adults in general as far as communication strategies or how to provide hearing care. And what we know is that for older adults with dementia, there are a lot of different factors that might mean that some of those recommendations are inaccessible or really not able to be utilized. And another factor related to this is that the ability to capitalize on these hearing loss management strategies requires the ability to access or utilize that care, and that can mean a variety of different things. Older adults with complex care needs are likely not equipped to navigate the hearing care process or adhere to the medical recommendations that are often presented. The arrows here kind of reflect the general steps in the process to successfully obtaining hearing care in the existing hearing care model within our current US-based policy. Persons with dementia are less equipped to navigate and participate in this fragmented service delivery environment, especially amongst other health needs, which likely co-occur for this population. And it's this inattention to the needs and capacity of these persons with co-occurring hearing loss and other conditions, again, like dementia, which may result in either unrealistic expectations for hearing device use and insufficient education or training for that self-management ability that often has to come. We're not able to effectively target care for these more vulnerable populations when there are significant gaps that already exist in the provision of accessible and more person-centered care. Understanding the influence of hearing aids on dementia and dementia's presentation and symptomatology is separate from how do we actually manage hearing loss for this group, and something that we have very little evidence to suggest so far. These current recommendations that you see listed here are essentially the same for younger populations as well. Unmanaged hearing loss, again, though, and the challenges with self-management ability or dexterity, remembering where a device is, the sensory integration of adding back hearing, sensory stimulation for hearing aids, all are challenges for that particularly can be hard for those with dementia and other conditions. And so it's this understanding of need and challenges of the complex care needs of dementia as dementia progresses, especially, which presents opportunity to integrate ways that we can think about hearing loss identification and hearing care within best practices of dementia care. As a field, though, there's a lot more that we must determine in order to support the clinical care and identification of needs within this particular group. Like I mentioned before, the lack of hearing loss management has the potential to exacerbate dementia symptoms or inhibit effective dementia care. Some of the recommendations for dementia care are continued social engagement, are continued communication with loved ones, or various different types of settings, which we already know individuals with hearing loss often withdraw from some of those types of preventative activities. In addition to exacerbating symptoms like anxiety, depression, aggression, things of that nature as well. We also know that care partners who are essential, and I'll talk about this a little bit more, for the care needs and facilitation of those with dementia, often are also the ones for older adults that are facilitating hearing care as well, and that self-management of how to use a device, battery changes, the ones that are often taking over the ownership of enacting various communication strategies that we already recommend. But currently, at least within the hearing care model and the way we generally practice, they are not systematically included and incorporated within the way that we provide hearing care. And then, like I mentioned before, and I'll talk about a little bit more, we also know that the current hearing care model of requiring kind of this disjointed and multi-step process for obtaining care can really strain care delivery and inhibit the ability to effectively access hearing care. And so, which leads me to my particular question of interest of how do we support older adults and those affected by hearing loss and ADRD or dementia, and what about their care partners who are so instrumental in effective care and care quality? What we know so far is that care partners are essential for those with dementia. In general for older adults, but especially for those with dementia. Some work by Jennifer Wolf's group that's using NHATS has demonstrated that there are over 18 million informal care partners that were identified within that are providing over 1 billion hours of care per month for older adults. And supporting more than 9 million older adults, some of them at the same time as also supporting, children or other family members. Additionally, over 1/3 of recipients that are receiving care have need assistance with at least 3 or more different self-care or mobility related needs. And over 1/3 of them, or over 1/3 of them, are also being supported by dementia, but that are taking up a disproportionate amount of the care time that caregivers are providing. What we don't yet know, and that we are actively engaged with members here, and Wuyong is one of the people leading the charge with this, is how does hearing affect this, how caregivers are able to effectively provide care, their care experiences, and the care that's ultimately received. And so some of the work that has been done by members in this room that was led by Wuyong is understanding kind of this connection between hearing loss and caregiving experiences. And using NHAT study, what we have found so far is that for individuals with providing care, there's about 16 more hours per month for those providing care for individuals with hearing loss compared to those providing care for individuals without hearing loss. And while this doesn't seem like an excessive amount, 16 more hours per month for individuals that have another job or other care activities that they have to involve can be an increasing amount of logistical and time that's not spent. Caregiving time, we do know, at least from the study, was attenuated in the presence of caregiving networks, meaning when there was more than just one primary identified caregiver, but there was a system of care that was in place of informal care. And that we also have observed, or Wuyong should have observed, I should say, differences in the types of care activities and the care demands for those with hearing loss and dementia status as well. Another thing that we are actively still investigating within the NHATS data is kind of this co-occurrence of hearing loss within care dyads. So looking at just subjective reported hearing loss, about 35% of the sample that we are currently looking at from 2022 indicated subjective hearing loss for care recipients. About 10% of caregivers reported subjective hearing loss or functional difficulty hearing, and the co-occurrence of hearing loss in both individuals of the care team was about 4%. In this year, we also were able to look at audiometric or objective-based hearing, and objective-based hearing loss was seen in about 74% of those that are currently receiving care. And about 5% of caregivers with subjective hearing loss were assisting older adults with measured hearing loss. And so that's think about the full population, that's a pretty large number of individuals. And what we have started to do and are actively still doing is looking at, well, what does that mean for the types of care that's provided in the caregiver's experience? And what we have found so far is that most, or about 55% of care partners, provide care for those with unrecognized hearing loss, meaning objectively measured hearing loss, but those that don't necessarily self-report hearing loss. And about 15% of caregivers are supporting individuals with at least, self-reporting difficulty hearing. Those that are providing care to those that at least subjectively indicate hearing difficulty provide greater assistance also with ADL or IADL-based activities, but not necessarily those with unrecognized hearing loss. And there's a suggestion that the time spent on care activities is about 1/3 less for those who, again, recognize that they have hearing loss compared to those that don't necessarily recognize that they have hearing loss. There's more that we're actively doing related to this and kind of exploring what does this mean for the care partners' experience or ability to effectively provide care to. But if we are to determine how best to support older adults with hearing loss and dementia, to obtain and then utilize hearing care, we also have to consider aspects related to the complexity of understanding how to navigate this hearing care process, and understanding that how older adults with complex care needs often navigate this process and what this means for how we approach our typical care delivery models. There's a lot that we still don't yet understand. Again, in the context of a lot of other health-related concerns. And so there were two key questions related to this that through the HEADS Center, I was exploring through, again, NHADS data and with support from individuals in this room as well. And specifically thinking about how to provide or support hearing care for those affected by hearing loss and dementia, in addition to kind of some ongoing work that, like I said, is going on here. I specifically was wondering about the role of care partners during this navigation of different medical care visits, and what does hearing devices and the use of hearing devices mean for those with kind of these more complex care needs. And so the first question that I asked is, what is the role of care partners during medical visits for those with dementia and or hearing loss? This was again using the NHATS data. And we reviewed responses for over 7,000 older adults from the NHATS survey and the associated NSOC or National Study on Caregiving from the 2015 survey, asking about care partner involvement. And then if the older adult indicated that they were accompanied to medical visits by an individual, we asked what type of role did that accompanier play during that visit, looking at exploring if there's differences by those with or without hearing loss and or dementia. What we essentially found is that, not surprisingly, care partners are highly involved in medical visits for many older adults. But more specifically, 25% of those reported hearing loss alone receive report with daily activities, which is not necessarily surprising. But 75% of those with hearing loss and dementia were receiving support with daily activities. Specifically, 40% of those reported hearing loss alone were accompanied to medical visits, but 80% with hearing loss and dementia. And if we then let's take a step further and say, well, if they're accompanied to visits, what are they doing? And what does that mean as far as how the role of dementia or hearing loss in this context? We see increasingly overall that individuals as, no hearing loss versus hearing loss, dementia only, or hearing loss and dementia. Increasingly, as an individual has more complex conditions, the care partners are actively more involved across the board. But that's especially the case as it relates to specific tasks related to an information exchange with a provider. either helping the adult understand the doctor or telling and asking the doctor pieces of information. These are the types of things that NHATS asked in that survey. And while dementia plays, a significant role in how involved the care partners are, the presence of hearing loss does make a difference as well. And so the next question related to this was, well, what about hearing devices, which are currently the gold standard for hearing loss? And if that is our gold standard, and that's what we're often recommending for individuals, especially those with more complex care needs and dementia, is that the best plan that we have so far, essentially? And so the question with this study was, how does the presence of dementia influence hearing aid use? And in particular, asking about hearing aid cessation. Wondering if for individuals that either obtain or get hearing aids, are they likely to continue using a hearing aid, knowing what we know kind of clinically and from other works, that challenges with dexterity, with increased sound stimulation, with remembering where the device is that individuals with dementia might have, is the recommendation to continued support of using a hearing aid the most accurate for this group. And essentially what we found is that dementia increases hearing aid cessation, not surprisingly, but those with dementia are up to 2 times as likely to cease hearing aid use compared to those without dementia. And that greatest risk is during the first year of use. We also found that social and economic factors have an influence on cessation. So individuals that have one care partner were more likely to continue to use hearing aids as compared to those that have either no care partners actively involved or that have multiple members of a care team or a part of a care network. We also saw differences related to insurance, Medicare and Medicaid, or no private insurance, where we saw differences related to that. Likely thinking that that might be related to just different types of support opportunities to support communication beyond just a hearing aid. And so ultimately, this kind of combination of understanding that care partners are highly involved, yet are not systematically included within hearing care, and our current gold standard recommendations for hearing devices for individuals with dementia might present challenges for overall supporting communication. There's opportunity to systematically support those affected by hearing loss and dementia by merging kind of a variety of care delivery practices with advances in health technology tools. And that's kind of where some of my more recent work has been exploring. And part of that is, or I should say, this is one piece of more of a larger collective body of work by myself and other colleagues that's much more centered in health services work and outcomes research, and this concept of access to hearing care again. Thinking about how we can inform ways of what access means, ways that we might be able to work within existing systems and health practices to better facilitate the care delivery more broadly, either in how people get to hearing care services or what those hearing care services mean and how they're able to support the self-management ability either by the older adult or their care partner. And we can begin to systematically focus on improving this care delivery through opportunities where we can kind of integrate pieces of health data from different sources that inform then how we're able to improve care. And this concept is central to a recent but growing shift in research thinking and care delivery to engage and directly integrate or embed the patient perspective into the care delivery process. And while this idea isn't groundbreaking, it's not yet systematically done in more broader clinical or research care. And it's rooted in this belief, again, that patients and families are experts in their needs and what works and should be active partners and members in their care and care intervention design as well. And this engagement then informs topics which matter to the patient, which can enhance service delivery, care management, and adherence, and improve interdisciplinary awareness and kind of care coordination, all things that are very important to those with more complex care needs. And then ultimately support more meaningful health outcomes. An alignment of that patient perspective with research and clinical care is fundamental to this idea of the learning health system, which is a vision for improving care articulated by the Institute of Medicine, this Agency for Healthcare Research and Quality. And it can be defined as a health system where internal data and experience are systematically integrated with external evidence, and that generated knowledge is then put into practice. And specifically, it's a system of care which seeks to align science and informatics and incentives and culture, and then again, that personal perspective and experiences with best practices that are embedded within that delivery process for more cycles of kind of continual quality improvement and study. For hearing, there are existing clinic-based tools which allow us to gauge effectiveness of best practice hearing care, HHIE, COSI, different survey or types of questionnaires that we are already using, but opportunity to systematically and pragmatically integrate those tools within our care delivery system or study hearing loss detection and diagnosis at the point of care really remains to still be utilized. And this is taken from it's kind of a framework or a thought paper done by Jennifer Wolf, thinking about how we can capitalize on ideas of the learning health systems to support dementia care and more systems level challenges that we see within dementia care. This idea of the learning health system presents opportunities for dementia kind of diagnosis and care and overcoming some of our known surveillance challenges related to that, as there's less need to rely on kind of the curated data sources like claims data or survey data for dementia diagnosis, and provides insight kind of specifically and more directly regarding care gaps and potential challenges or targets for intervention, but are from areas that are much more connected to health systems and actual diagnosis of care. This idea of the learning health system and different tools within it kind of has an increased representation of older adults with dementia that in many studies is especially harder to come by, which can support kind of better investigation of disparities in care delivery, specifically for dementia care as well. It provides an opportunity to bridge kind of clinicians' experiences in different settings across different silos of care and facilitate care coordination and connection and communication across different disciplines. Also has presented opportunity for engaging care partners, which, like I said before, are highly involved in the care delivery process and support strategies which help providers learn how to best manage and provide care in ways that they can be more directly engaged. And then all of this kind of drives care redesign for dementia care as we continue to learn and health-related technology tools evolve. And one way that a lot of work has started to come from studying kind of this idea of the learning health system is not necessarily just using data obtained from the medical record, but also data from the patient portal. It's one example of how to do this within current systems of care, because the patient portal is one of the most widely available consumer health information technology tools. And uniquely from this, we can explore how patients use the portal to facilitate care, as this is a secure online platform, Hopkins, it's Epic, to facilitate care communication between patients and families and providers, and then health systems more broadly as well. The patient portal utilization for health services and management has been increasing nationwide, and there's a lot of national initiatives that are centered on increasing utilization of the patient portal across health systems. And I'm attempting to summarize a very elegant series of work by one of my colleagues, Kelly Gleason, who's in the School of Nursing, who put forth a number of different papers, kind of trying to understand patient portal utilization for older adults, both in how they're using the portal and in understanding how scientists, researchers, and clinicians are using the portal potentially for intervention or identification. And importantly, within all of this, the portal is increasingly being used to collect assessments and disseminate education to patients with a growing number of innovative models on how to do so, or to provide nudge interventions for providers or families for different specific types of care delivery or preventive care recommendations, for example, all of which is being deployed through the portal. While conducting a systematic review of the literature on portal use and intervention design, as well as using kind of existing data, which I'll describe in briefly, what we essentially have found is that portals are increasingly being utilized across health systems. The patient portal use is high, at least within Hopkins, and this is kind of echoed in other studies, where about 60% of individuals, older adults in particular, are actively using the portal, not necessarily registered and have access, but are performing different tasks or functions within the patient portal. And that is regardless of dementia diagnosis. We also know that proxy and care partner registration, while is not necessarily high, a proxy or care partners are actively using patient portal registration either by themselves or on behalf of the patient, and how they're using that does differ by dementia status. Most interventions that we have seen through the patient portal are providing education or are collecting patient-related health information. Few have so far pragmatically been looking at implementing kind of health systems-wide initiatives and ways that are embedded. They're still requiring active kind of personal manipulation of sending messages or collecting pieces of information. But the tools are in place to be able to have things that are more embedded and pragmatic that might support more systems-wide types of initiatives. This collection of information really presents an opportunity to explore how these different changes in technology and this vision for the health system and delivery that's engaged currently, or vision for how health delivery of hearing care can really be utilized for, let me backtrack, how this growing collection of kind of resources that relates to the patient portal, this understanding of care partners involvement, and kind of where we're falling short on how we provide hearing care, presents opportunity where we can think about ways to kind of make use of all of these different tools to better support older adults with hearing loss and the current challenges that we're facing. And all of this kind of was the inspiration for my current funding, knowing again that communication in health is increasingly important for older adults, and that care partners are essential for facilitation of all of this, including those with hearing loss and dementia. But they are currently disconnected from the current care delivery pathway, and this particular population really remains poorly supported so far. In addition to the fact that we know that this particular population has unique needs, but understanding what these needs are and providing better access to facilitate care for these needs really has the potential for higher value care, whether it's related to hearing care or dementia care. And so my current goal is to identify strategies to better support older adults and the care partners of those with Alzheimer's disease or related dementia and hearing loss as well. And this is funding through the Alzheimer's Association. And ultimately, one place where we can start to begin to both identify individuals with hearing needs and integrate that patient collected information, which is so valuable for providing patient perspective within existing systems that are in place, is the Medicare's annual wellness visit. This visit, which was introduced in 2011 as part of the Affordable Care Act, is a reimbursable visit specifically focused on preventative care for older adults. And while it has been slow to kind of get started and get its footing in the necessary supports for different kind of healthcare clinics and systems, the utilization of the annual wellness visit is increasing, and about 65% within the data sample that I have here at Hopkins of eligible individuals for this visit have had at least one annual wellness visit, if not more annual wellness visits. So its adoption and facilitation is growing. And importantly, other studies have demonstrated benefit for various aspects of preventative care for individuals who have received an annual wellness visit, including increased dementia diagnosis, cancer screenings, or flu vaccinations, but it hasn't really been studied for hearing care. And that's particularly interesting because the annual wellness visit reimburses clinicians to perform a health risk assessment, including a screening for hearing concerns. And so for Medicare patients, the hearing screening is a required element of Medicare's annual wellness visit. And with this current landscape of resources which exist to collect, address hearing concerns, kind of more at the point of care within primary care, where a lot of these visits are taking place. How these visits are performed really varies across health systems. The data I present today comes from Hopkins-based study, and how the health risk assessment performed here collects information, at least as it relates to hearing, is based off of this question: are you deaf or do you have serious trouble hearing? And while we can kind of talk about what that construct means, if somebody says yes to this question, they have active difficulty hearing. And so what my initial what I was particularly interested in understanding is, if somebody indicates that they are deaf, say yes to this question, what happens next within primary care, and what does that mean for how they access hearing care services? And so one of the first things that we have sought to do is to understand within this study is to evaluate the role of primary care visits in relation to hearing care detection and service use among older adults with ADRD and hearing loss as identified through that Medicare annual wellness visit. And again, this visit is often being performed within primary care settings. And we know that integrating delivery of the annual wellness visit into clinical practice is time intensive. It requires, while it's not necessarily a physical exam, there is a lengthy questionnaire, which I'll describe briefly, and a handful of other types of aspects which are collected, which does require a little bit more time. And so has some necessary supports are needed. But again, while increasing this visit still does remain somewhat underutilized in different types of health settings. But there are opportunities to explore ways that we might systematize and improve the workflow of the annual wellness visit to facilitate its integration within care. And Hopkins has started to include utilization of annual wellness visit questionnaires and different tools within the patient portal for integration and ways to explore kind of what that means for service delivery and action from patients and providers later. And again, while this is still overall underutilized nationwide, that growth is continuing, and the patient portal could be a tool, like I have suggested. We're seeing evidence of its use to facilitate access to information about the patient's health, including patient-generated health information, and a tool to embed strategies to facilitate access or care or disseminate information as well. One of the ways that we can include, directly embed and include this in collection is the collection of the patient-generated health information, like the health risk assessment, which includes hearing concerns directly embedded within the patient's chart for responses, and to then integrate those clinician responses or actions towards hearing care, which is what I'm particularly most interested about, and what kind of we'll walk through a couple steps of what we're starting to explore that with. And so we embarked on a series of studies to explore kind of what these questions mean and what the potential of the annual wellness visit to consider addressing hearing concerns means, and what the patient portal might be able to support within that process. And so the study sample we are working with for this data is from Hopkins-based system, where we have the electronic medical record and patient portal data for patients aged 65 years and older who have had at least one visit within primary care between 2017 and 2022. And specifically for my study, I'm interested in those who have had at least one annual wellness visit, which is about 14,000 individuals. And looking at that 14,000 individuals who had an annual wellness visit, we first wanted to investigate how they responded to the health risk assessment questions overall, and how this relates to their patient portal utilization. And so the particular questions of study for this was to first just characterize the annual wellness visit and the health risk assessment completion, both overall, who's receiving this visit and how are they responding, and then how does that relate to portal-based messaging, as patient messaging on the patient portal is one of the primary use tools because it allows patients and families to connect with their provider and more directly communicate and facilitate exchanges of information. It also is increasingly added burden and time commitments for providers. And so finding ways that we can both potentially minimize or support patient-related information that doesn't require messaging is an opportunity that we can help facilitate information education for patients. And then also wanting to understand how we can describe implications and the value of patient portal-based integration and electronic resources, and understanding if we do choose to do this, who are we reaching and who are we not reaching with portal-based intervention design. And so specifically our final sample, from our final sample of eligible older adults for Medicare annual wellness visit, we have not quite 13,000 individuals. About 8,500 of those who are eligible for the annual wellness visit were billed for at least one annual wellness visit during this 5-year period. And overall, those who had an annual wellness visit were slightly younger, were more likely to be white and married, and about 80% were active portal users, although portal use, like I had mentioned before, remained high in those even without an annual wellness visit. And those with an annual wellness visit overall were slightly healthier than older adults who did not incur an annual wellness visit during that 5-year period. And we first wanted to investigate how older adults were just responding to the different components of that health risk assessment, which does include inquiry into both hearing and cognitive concerns. At Hopkins, the annual wellness visit health risk questionnaire was harmonized across 28 categories, and then we grouped them overall into physical health or social and behavioral related health domains aligned with the promise domains to kind of understand risk within each of those. And so we sought to characterize the frequency of endorsement of each of these differing health risks by portal use, and then from there to gauge the potential for portal-based intervention or educational opportunities of these patient-identified health risks. And what I have pulled here is the top 5 risk categories endorsed, putting aside reporting that the patient sees other providers, as this isn't exactly a health risk per se. But comparatively, while there are similarities across categories which received the greatest endorsement, if we just look overall at the frequency of endorsement, non-portal users had a higher frequency of endorsement for given health concerns across the board compared to active portal users. And we then evaluated frequency of health risk endorsement categories and domains as % differences by portal use, active portal users to non-portal users. And I say active portal users, meaning the individual has registered portal account and has logged in and completed at least one activity over a given year. This graph depicts the % difference in endorsement on the y-axis and the different health risks inquired on the x-axis. Those in the social and behavioral domain are the lighter dashed bars, and the physical domain are the dark solid bars. And categories with significant differences by portal use are marked by the asterisks at the bottom. And overall, what we can observe here is that there are differences in endorsement by portal use, with active portal users' responses suggesting healthier behaviors, less dependency, and greater engagement in preventive behaviors compared to non-portal users. And then when considering what this endorsement of health risks may mean for care delivery and interactions with patients, we then evaluated how simply the number of health risk categories endorsed relates to the number of portal messages requesting medical advice. And we found the mean number of messages was overall incrementally greater, with greater number of endorsed risk categories, fluctuating from about 14 for those with no endorsed categories to about 20 for those with 10 or more endorsed categories. And while not depicted here, portal messaging was greatest for physical health risks, common among older adults, including poor self-rated health, ADL difficulties, pain or fatigue, cognitive concerns, and then needs related to housework. And so in summary, for this particular study, 8 in 10 individuals eligible for the annual wellness visit, we did find were active portal users, at least within this health system. Active portal users generally endorse fewer preventive health concerns. Increased portal messaging was observed among those with endorsed physical health domains or greater number of risk categories. And ultimately, portal-based administration of the annual wellness visit health risk assessment or tools, we did find more likely will ultimately be reaching a healthier population, which is not necessarily surprising. But if we're considering how we might be able to use the patient portal for educational programs or materials, it's important to know who we're potentially reaching. And so for the interest of the annual wellness visit as a potential place to begin to identify those with hearing concerns and think about what happens and how they access care, we can take the annual wellness visit completion and their responses a step further by looking at specifically what happens within the care visits or systems of care for those who have responded in particular ways. For example, for those who have responded and indicated that they have difficulty hearing. And so from our overall sample, we then pulled about 3,800 patients with an annual wellness visit who indicated hearing concerns for the first time at an annual wellness visit during our sample, and wondering what happens from there. And specifically, some of the outcomes of interest that we were curious about is, what does that mean for hearing diagnosis, or does that differ for hearing or dementia diagnosis in the medical chart, and the type of diagnosis? Looking at both visit diagnosis, which is a diagnosis put in the medical chart often attached to a visit or for a referral, or if the diagnosis is included on the patient's problem list, which is more widely viewed across care teams and health teams as a health identified problem. The optics or who's able to see the different diagnosis code can vary. And then in particular, in a sub-analysis of a random sample of patients, we then review the annual wellness visit clinic note, exploring how clinicians documented or elaborated on hearing concerns, if they acknowledged hearing concerns that were indicated at the annual wellness visit first time, or hearing aid use as well, and then written recommendations of referral for hearing care essentially asking if somebody has said they had hearing concerns at this preventative care visit, what happens? Again, looking at characterizing first who indicates hearing concerns on the annual wellness visit overall, both by characteristics and if they had an existing EMR diagnosis of hearing loss, and then describing how those hearing concerns were recorded. And so first, who indicates hearing concerns? About 25% of the Medicare beneficiaries indicated hearing concerns for the first time during this window. I don't have it documented here, but about 75% of the annual wellness visit individuals or beneficiaries who had a visit completed the full health risk assessment questionnaire. And among those who did not, it was not commonly hearing related questions that were missed. So most of the individuals within this sample were answering this question of, do you have hearing concerns? Or are you deaf or do you have significant hearing concerns? And compared to those who do not indicate hearing concerns, those with hearing concerns were more likely to be older, less likely to be female, white, and not married, as recorded at least within the medical record. And we can see here that while portal use in our sample is overall high, like I mentioned previously, those with hearing loss were less likely to be registered for the patient portal and were less likely to be active users. And then about 25% of those who reported hearing concerns had a medical record diagnosis of hearing loss with existing, and even about 8% of those that indicated that they did not have significant hearing concerns on their annual visit had a diagnosis. And so if we then looked at provider discussion of hearing within the visit chart note, a priori, we set out to begin to characterize and quantify the extent that providers do discuss or document hearing within the annual wellness visit. Again, because this is a focus on a preventative health visit. And we know that what prevention means for different Medicare beneficiaries could be very different. Prevention efforts for someone with 6 or more chronic conditions is likely very different than for someone with 1. And this context might change how providers or clinicians approach any given health condition that a patient indicates. We set out to flag 3 different things. First, if the clinician was able to elaborate on the indicated hearing concerns within the visit note, if the clinician acknowledged a known hearing loss or hearing aid use within the visit note, and then if they also indicated referrals or recommended a referral for hearing care of some kind, whether that's audiology or ENT for needs that were related to hearing. And within those sampled, about 20% had an existing diagnosis of hearing loss as recorded in medical record, like I mentioned. We didn't observe differences in who did versus did not receive a referral to hearing care within the medical record within kind of a brief window around the annual wellness visit. But overall, that number is pretty low. There are overall differences in the extent of inclusion of hearing concerns within what the clinician records within the clinical note regarding care discussions about during the annual wellness visit, clinical visit. For those without a hearing loss diagnosis and their indication of hearing concerns for the first time, only about 1/3 received elaboration of concerns in the clinical note, basically anything more than that they said yes to that answer of the question of hearing concerns. For those with an existing diagnosis, this was slightly higher, but still a lot of individuals, there's not any record of information related to hearing. And then a similar story is also seen for clinician documentation of acknowledging a known hearing loss or hearing aid use. While understandably higher for those with a hearing loss diagnosis in the medical record, still only about 1/3 of those where a known hearing loss was documented in the note, didn't have any indication in the medical record as well. And if we explore what that diagnosis looks like, we can see that the majority of diagnoses are for visit diagnosis, whether for referral purposes or again, due to diagnosis from a medical visit. Importantly, very few have a hearing loss diagnosis on the problem list, the diagnosis type that is most visible across care teams or across care disciplines, letting other providers or care teams know that hearing challenges, communication ability, or other health-related needs might be affected by just oral communication. And in a subgroup analysis, we see some differences in clinician documentation with clinicians, not surprisingly, elaborating on indicated hearing concerns when the patient has an existing diagnosis of hearing loss in the medical record, or for patients who are over 80 years of age. And again, not surprisingly, we see clinicians are much more likely to acknowledge a known hearing loss with an existing diagnosis of hearing loss, or for females compared to males, possibly due to differences by gender and how older adults discuss hearing overall. But we also see that clinicians are much less likely to do so for older adults with 3 or more chronic conditions. Again, likely related to other existing health needs that take precedent over likely hearing for older adults with more complex care needs. And so we know that gaps remain in, or essentially can understand that gaps remain in harmonizing Medicare beneficiary indication of hearing concerns and that clinical note documentation or facilitation of hearing care. And while clinicians may elaborate on hearing concerns or acknowledge a known hearing loss, this indication is not often recorded in the medical record for notification across care teams, like that problem list, like I mentioned, which means that patient follow-up for hearing concerns really becomes patient-driven and patient-navigated. And challenges of focusing on hearing concerns in the face of additional chronic conditions requiring complex care significantly exist, which may inhibit older adults and their care partners in particular ability to kind of access care. And so if patients with more chronic conditions are likely requiring complex care and are less likely to have hearing discussed at primary care, what about those with dementia? When there is evidence to suggest, like I said before, that hearing management might support cognitive health or dementia care goals. So we took that same analytic sample of those who had indicated hearing concerns for the first time and essentially embarked on the same analysis, but this time looked in to see if the findings differ by those with or without dementia diagnosis or indicated cognitive concerns, and are actively working on this now. And so among 2,500 individuals included, about 7% had an existing dementia diagnosis ascertained via an algorithm that has been used in other works, and then also within kind of this ongoing work within the Jennifer Wolf's team. No differences were observed in existing hearing loss diagnosis or in referrals made to audiology or for hearing care following the indication of index hearing concerns. Again, but overall referrals were low, at least as it's recorded in the medical record. And what we can observe is that hearing concerns are frequently not discussed overall, even within an existing hearing loss diagnosis. So clinicians are much less likely to elaborate on initial indication of hearing concerns for those with dementia compared to those without dementia diagnosis or that indication of cognitive concerns on the annual wellness visit. And in relation to clinician acknowledgement of a known hearing loss, clinicians or primary care clinicians are more commonly indicated a known hearing loss for those with dementia if an existing hearing loss diagnosis was already in the medical record, but not so if no hearing loss diagnosis exists. And even when adjusting for different socio-demographic characteristics, clinicians were about 50% less likely to elaborate on or acknowledge hearing loss for those with dementia compared to those without dementia. We know that completion of an annual wellness visit, though, for those with a dementia diagnosis is really a select group, as is due to the preventive nature of the visit and the fact that many patients with dementia have additional or complex care needs again. But this does not mean that hearing concerns are ignored, again, for lack of a better phrase. It does suggest, though, that in the context of other pressing healthcare needs, hearing is not necessarily tended to within primary care. And we know primary care physicians already have a lot on their plate, and yet this is the place where this population and this generation seeks their health education and information and where to go to access different types of care needs. And so it remains increasingly challenging for patients to understand how to seek or access hearing care, to understand the importance of hearing care in this particular context. And so that's at least what we can see is what's happening within the medical visit from medical record or patient portal-based data. The other half of the work that we are doing currently is to essentially conduct semi-structured interviews to elucidate barriers, needs, and opportunities to better support hearing care detection and care among older adult primary care patients with dementia and hearing loss, their care partners, and primary care providers. To gain a perspective on how primary care and then the health system overall may be more supportive of the ability to access and understand the needs of hearing care. We're actively recruiting eligible older adults, these care partners and clinicians. When I changed from here to Maryland, that made it much more challenging to implement the plan that I had in place, going to a different university and system. So that's been a little bit slower to get going, but we have 5 interviews completed and transcription is currently in progress. I know this is similarities to some of what is being done here within the Cochlear Center as well. So hopefully kind of we can pool information from there. And what I hope to do, kind of combining all of this work, is to have a better underway of how we can essentially support how the essential care partners for those with dementia and better understanding how hearing care might be able to be facilitated and implemented and essentially accessed. To do so would be to also fill gaps in hearing care and dementia care, and then strategize ways to educate or facilitate care in systematic and less burdensome ways that aren't not necessarily asking primary care settings to do another task, but to kind of work within systems that are already in place and data that is already collected and tools that are already existing. And then to understand the potential for scalability within and across care teams or health systems. There's kind of a continuum of innovation which exists, an opportunity to kind of work within different levels of leveraging the health systems for patient portals. Patient portal registration is significantly existing, and there's been work demonstrating the effective use of existing kind of functionality within the patient portal. Less so, and my particular focus for future study is understanding how we can incorporate this patient and care partner generated content like the collected health information from the annual wellness visit, and then utilize that information and identification to disseminate portal-based video, print educational resources or referrals or tools to help enable that understanding of how to access hearing care. And within that, to provide scalable strategies to improve individualized care for those with hearing loss, and particularly those with hearing loss and dementia and their care partners, because they're a uniquely vulnerable group. And then within that, to bridge person-level challenges with system-level supports is ultimately what I am slowly working my way towards, hopefully. And with that, I have 5 minutes to spare. Thank you. Yeah.
So we're working right now to get the microphones turned on in the room so we can open it up broadly for questions. No microphone is needed. You can just go ahead and state any questions you may have.
Other than looking at the problem list and like the diagnosis codes on the visit, have you considered looking at like the flags on the patient's record? Because I feel like a lot of times, even when patients have a diagnosis on their problem list, they still don't get a flag. And
Yeah. I mean, the flag is something that's, I know, individuals here have been working on implementing for flagging hearing. It's not universal as far as across health systems. The problem list is more universal and it's meant to be a flag.
Yeah.
That's harder to collect within the data that's pulled from the medical record. But they're trying to serve a similar purpose as far as like informing care teams of things that might be of use. Yeah, but that's something that we don't necessarily have pulled. We have the problem list and then the visit diagnosis, which is kind of a much more narrow and limited in the sense of the diagnosis is needed for referral, and to access hearing care referrals needed for this group. So it's the problem list was what I was more interested in than the visit diagnosis.
Yeah. Have you been looking at the different, so I know at Hopkins, there are different types of problem lists. So there's like patient reported, doctor reported, actual diagnosis. So
I just have full.
Okay.
I don't have the data for it. Yeah.
So Danielle, really love it. I mean, super methodical approach to thinking about how like where hearing care fits in within a existing health system portal. Do you mind going back 2 slides, that little pyramid thing we have?
Yeah.
So eventually you'll get to this point with a future study.
Yeah.
And then we think about, scalable, digital resources you can implement for the portal, go through the portal like that.
Yeah.
So the penultimate top thing. What do you think those will look like? If you had to put like imagination, like what would that be? Like literally a short video? Like
Yeah.
how do you leverage a scalable digital platform to actually educate
Yeah.
care providers, patient population, like
So,
what would that be?
Couple thoughts on that. I can say what I think it would be, but what I am actively writing for a submission this fall is an NIA impact collaboratory grant on essentially studying that and what is this population, what do they want? Some of what I've learned from the 5 interviews that we have done is essentially primary care tries, but given their kind of, handouts work so far, it might be videos, it might be a nudge through a message through the portal of, hey, think about accessing this, or have you thought about this? It could be, a handout. I don't know exactly what that could be. There's a lot of existing videos and things that are already there. It's just getting people connected to those things that already exist. The other thing that has come up in this interviews that we've already done is just understanding what is a hearing aid versus the OTC options. And what does that mean and how should somebody be thinking about that? Same thing from the providers that we've talked to. Because we're also asking them like, what do you know, what do you want, and what would be useful? But I could see it as a couple different ways. I could see it as print, I could see it as embedded video, I can see it as just links to existing tools. What I'm trying to figure out is the best way for this particular population where a lot of the existing tools that are out there might not really be appropriate.
Really question.
Yeah.
If you've seen it, I mean, I think, I probably use my chart more than I do, but I don't,
Yeah.
but if, for people, I mean, it's this obvious in the first instance where they're trying to create digital resources through a portal,
Mhm.
sorry, not portal. Do you know typically just logistically, let's say the Epic system that Hopkins wants to do it, where do they pull those resources from? Are they created by a third party? Are they licensed from CDC? Like who actually makes it? How do they make it available?
Yeah, I think, I'm gonna have a somewhat uninformed answer for that. So a lot of the model of kind of how to even go about navigating this is through colleagues within kind of the bigger study that this work is coming from at University of Colorado Health. They have specifically worked in a platform for a dementia care clinic, a seniors clinic, where they're thinking about strategies, whether it's embedded videos. They have actually a chat bot that has a series of questions related to dementia care. What could you be interested in? And they are facilitating and populating those resources specifically themselves. And working within their Epic team as far as how do we do this? How do we then pull the data so we can understand, is this like, how is this being utilized? And is this actually effective or not? And starting to kind of collect analytics from there. But I think it's a combination. Usually it seems, at least my experience so far has been clinician driven as far as how it's populated and pulled. I don't know if that's answering your question specifically.
Offline.
Yeah.
I have one question from the chat.
Okay, so and then we need to finish up because it's 1:01.
This is from John Swen. Did you observe a difference in the group mean age between active versus non-active
Yeah.
patient portal users? I'm thinking about tech literacy as a potential barrier.
Yeah, no, that's a huge topic related to this, absolutely, and there are differences. There are differences, those that are active portal users are who you would expect, more educated, slightly younger. And so recognizing that was part of why we did the initial study of like, who's getting the annual wellness visit, how are they responding in their use, understanding if we did think about any kind of intervention through this, who are we accessing versus who are we not? But there's a lot of, room to think about existing, health literacy levels and then future health literacy levels as individuals age that are more accustomed to using digital health tools. Care partners are increasingly becoming more involved. There's this understanding of kind of the connection of where we are now, who is actively using and where we might be in a handful of years, and trying to kind of be aware of it. But yes, there's absolutely, potential bias in who we're accessing through it and understanding that.
I think, given the time, we probably need to wrap up, but Danielle, I just want to thank you again so much. Like, what a beautiful body of work and so beautifully presented. And it's just so exciting to see how much that you've done in the very short amount of time that you've done it, which makes me really look forward to future great things. So really appreciate it. Thank you. For our trainees in the room, remember that there's a meeting with Dr. Powell immediately following this right across the hall. And for everybody, Cochlear, on the way out, if you'd like to grab lunch, feel free. It is opening day and in what has to be like the cutest like joint theme ever. Like it's hot dogs and hamburgers and Cracker Jack over there. So go O's, and yeah, please be sure to grab lunch. And thank you again, Danielle, so much for an amazing
Thank you.
seminar.